atelectasis. And overall,
today, which is my most exciting part. Hopefully, awake. Based on AFP articles that come out over the years, there's been minimal on scoliosis as far as management, what we do with it, over the last, probably 7-8 years. So, you guys may feel like I got a good grasp on all this, and this is review, but that's okay. Reviewing is still a good thing to do. So that's kind of the game plan. Get to the end of that, and hopefully you've learned a few things. So, what's scoliosis? Well, it's a lateral curvature of the spine. Actually, usually there's a rotational component as well. It comes from a Greek word that means crookedness. Kyphosis, which is another curvature of the spine that you may see at times, is an anterior curvature, and then some people have some increased lordosis, which is way less common to see or be anything pathologic, is a posterior curvature of the spine. So those are kind of the terms you use when you're describing spine position, when you're looking at an x-ray or talking about some imaging. How do you define scoliosis? Well, by the Scoliosis Research Society. So if you're doing a study, go by their definition, which is a lateral curvature greater than 10 degrees by the Cobb method on a standing x-ray. So that's how you would define somebody that has scoliosis. If it's less than 10 degrees, it's probably not really scoliosis.
Awesome, thank you.
So the types of scoliosis that you might come across, there's infantile, juvenile, and then adolescent. There are secondary causes of scoliosis, which we don't call idiopathic. And there are kind of 3 big categories that can cause that, which are neurologic issues, some neurologic problems, musculoskeletal issues, which we'll talk about both of those things, and some connective tissue disorders can all cause more secondary causes of scoliosis. So by far and away, the idiopathic cause is what we're going to come across most of the time. But you just need to be aware of some of these secondary things in case something just doesn't quite seem quite right, or maybe you're astute enough to pick up on some things that make you think this is just not the typical scoliosis that I've seen. Musculoskeletal things that can cause scoliosis, a leg length discrepancy can cause it. So that's sometimes hard to pick up, but it's something that probably you should look for in everybody that comes in with scoliosis. Hip dysplasia, osteogenesis imperfecta can be a cause of scoliosis, Klippel-Feil syndrome, and you can also have just failure of spine segmentation. So, that's why we get radiographs to find some of these secondary reasons that someone may have the problem. Neurologic issues can be in some ways a little bit more ominous, but so spinal tumors of any kind can cause it. Muscular dystrophy, cerebral palsy, syringomyelia, which is kind of fluid in the center of the spinal cord, can cause scoliosis. A tethered cord is a problem that can do it, and there are others as well on the list, but those are kind of the main ones that you might come across. So connective tissue disorders that can be associated: Ehlers-Danlos, Marfan syndrome, and homocystinuria. So, just things to kind of keep in mind on your differential, things that you may choose to work up or look into in certain cases that may come into your office for scoliosis. So I'm going to limit my talk basically here to adolescent idiopathic scoliosis, because by far and away that's what you're going to see the most of. Some of the things picked up at a juvenile or infantile, although you may be the doc that delivers the kid, you're probably going to quickly, if that's picked up, that's going to be taken care of probably by a subspecialist in some way, and not you as a family doc. But so 9 out of 10 cases of scoliosis are going to be in adolescents. It actually affects 1 to 3% of adolescents in the U.S. With curves that are actually less than 10 degrees, which technically isn't scoliosis, boys and girls have that same amount. So sometimes you get people that think there's a curve, or it just kind of happens to be picked up on a spine x-ray, and they get sent to you for some reason. Those small curves, they're going to be boys equal to girls. But in curves, as they get into a greater amount of degree, girls outnumber boys by 10 to 1. And also clinically significant curves. So those curves that you're starting to intervene or do something more than observe, those greater than 40 degrees that have progressed really to that point where there might even be intervention surgically. They really don't happen that often. It's 0.1% of all the cases of scoliosis that are out there. You classify the age of scoliosis based on the age and when it's first identified. So this will be the last time I'll talk about the other 2 types, but this just kind of gives you the definitions of infantile, juvenile, and adolescent. So basically, adolescent is kids 10 to 20, in the age of growth. Infantiles up to age 3, and juveniles is in that in-between range. You can see some of the ratios there, male to female. Infantile is the only one that is more common in males than females. Again, very small percentages to come across. The other thing that's weird about infantile is it tends to be more left thoracic curve, which is defined by the convexity of the curve, whereas adolescent and juvenile tend to be more dextroscoliotic or right convexity to the curve by a pretty good ratio, 6 to 1 and 8 to 1. So what causes it? There's really no defined cause of scoliosis. Like everything, there's genetics that are involved, and we'll talk about some of those things. But really, we still don't know. That's why we call it idiopathic. Scoliosis in sports, this is just a couple quick slides, but it has been seen a little bit higher, more often in swimmers. We're not exactly sure why that's the case. Maybe it's because of some of the imbalance in musculature, having really strong anterior muscles for pulling and less strong posteriorly. Plus, kids start in swimming a lot of times at a very young age. They get, they might get competitive if they show some promise. So it is seen a little bit more commonly in swimming. Gymnastics also seems to be a 10-fold higher incidence than the general population. Again, really unknown link. There's some, maybe delay in menarche and generalized joint laxity that may be associated with those that, get involved in gymnastics. Again, it's a sport that kids get involved in at a young age as well. So maybe there's some of that contributing. But in the end, we really don't know why this is the case in those two sports. So the there are genetic factors, obviously, in causing scoliosis. There's been really no single mode of transmission identified. There's been some, studies, investigations done showing a multi-gene dominant, with variable expression. Monozygotic twins have identical curve progression, which makes some sense. It does seem to run in families, but the severity within that family may vary. Interestingly, if you have both parents that have scoliosis, 50-fold higher chance that their kids have scoliosis and that they will require treatment for it. So that's, there's obviously a genetic component. Nobody's identified any single gene, or it's not any, the way it's passed on is quite variable. So just some interesting things to kind of keep in mind. But there really is, and the bottom line is there's really no role for kind of genetic testing and in diagnosis or management of scoliosis when this comes in your office. So what are you going to do as far as history? Kid shows up in your office for whatever reason. Probably one of the biggest things is like, how did you end up here? Sometimes kids are picked up on screening. Sometimes a relative looks at the child and that's not around them all the time. Like, their back looks crooked. You need to go get it checked out. And they're having no issues with it whatsoever. So probably a good question is like, how did you end up coming in? What were you worried about with it? Get a good family history, find out if, parents have had it or been told that they have it. It seems to run in the families. And then, probably the key things are thinking about those things that cause secondary scoliosis. So ask questions looking at, connective tissue disorders, any neurologic issues. And then probably a big thing is it painful? Most scoliosis doesn't cause severe pain as far as idiopathic scoliosis. It can cause minor discomfort or discomforts at times or certain situations. That's fairly common, but kind of significant pain or severe persistent pain is not a typical symptom of idiopathic scoliosis. Respiratory symptoms can happen, but typically those are curves that have progressed quite a ways and are quite severe by the time they might see you. So again, typically painless, or if painful, the pain is mild. If they're having significant pain, think about other things such as fractures, tumors, syringomyelia, malignancy, infection, disc problems. So again, kind of something doesn't quite seem right. Pain level seems to be more than what you think is significant, seems reasonable. But you know the kid pretty well, and might warrant looking into it more than you might otherwise. Back pain actually is more common. People have adolescents that have scoliosis compared to the general population. Doesn't really result in disability, and really the amount of curve that they have doesn't seem to correlate necessarily with the pain severity. So things you want to ask about as far as their neurologic development, has their neuromotor development been normal throughout the stages of development? Are they experiencing any paresthesias, weakness, bowel or bladder dysfunction? Kind of the very common things you're going to ask, hopefully, with anybody that comes in with back pain. some of those red flag things that you think of and ask about. And then respiratory symptoms, again, usually pretty severe curves. If they have greater than 100 degrees of scoliosis and 65 degrees of kyphosis, honestly, if somebody walks into your office that's fat curved already, somebody's missed it along the way, because it's pretty obvious deformity in those cases. So, most of the time people are going to show up in your office with respiratory complaints. What about screening? Has anybody here been involved in scoliosis screening? Okay.
Right.
Dr. Tim?
My school used to do it.
Okay.
When we were younger.
Yeah.
The school nurse would.
So you remember growing up getting scoliosis screening? Yeah, so I mean, it's been something that's been around for a really long time. Back in 2004, which maybe some of you guys, none of you guys have been in elementary school around then. No, I'd be on.
Elementary, middle school.
Close, yeah. I mean, it usually happens in middle schoolers is the age that people typically start screening. But back in 2004, AFP, U.S. Preventive Past Services Force, they said there really is not good evidence to recommend for routine scoliosis screening in adolescents that are asymptomatic, because there's really there's no good evidence that it affects in any way the patient-oriented outcomes that they looked at. There are some other societies, the American Academy of Pediatrics, American Academy of Orthopedic Surgeons, and the Scoliosis Research Society that still support screening of females twice, first at age 10 and then also at age 12, and males once, sometime between the age of 13 and 14. So choose to listen who you want to listen to, I suppose. I mean, you probably as a doc aren't going to necessarily set these things up, but I guess just be aware that there may be some places that are still screening potentially. And because of that, that may be the reason the kid ends up seeing you or calling your office to be seen. All right, so what do they do screening wise? Well, most places are going to have you do the forward bend test, which you could kind of picture showing what that would look like in the normal situation and abnormal. So subject basically kind of like puts their hands together, bends forward, tries to reach towards the floor. You want their spine to get as close, forward flexed as you can, and you look down the plane of the spine, looking for a rib hump on one side compared to the other. The sensitivity is anywhere from 92 to 100% for curves more than 20 degrees. So smaller curves, it's going to be a little harder to pick it up, but something that has a curve at least 20 degrees or more, you're going to see some deformity. So that in that situation, well, this is at least, likely a significant curve that probably somebody should at least x-ray, in a still growing kid, and kind of see where things are truly at. You also might see people that have used the Scoliometer. Do you guys remember this getting put on your back? For those here that said they were screened. So it's this little thing, it's got a little silver ball that kind of rolls back and forth. They lay it across, and it measures the angle of trunk rotation. So how good is it, for picking up a curve greater than 10 degrees, which is by definition what scoliosis is. If you use a scoliometer and use a cutoff of 7 degrees of trunk rotation, there's your sensitivity and specificity. So you're pretty good on both. You're not going to, have too many false positives or false negatives. If you drop that amount of degree and go to a smaller amount to call it scoliosis, your sensitivity goes up because you're going to, include more people, but your specificity drops significantly. You're going to have a lot more false positives, so the spine surgeons recommend the 5 degrees of trunk rotation on a scoliometer as your cutoff. There's some incentive in that, if you're a spine surgeon, you get more, kids coming into your office and those kinds of things. So there may be some of that reason in using that cutoff. So, again, if you choose to use this measurement, you can pick what cutoff you might use as far as starting to work a kid up.
Is that measurement to refer or to get like a copy?
So that's a measurement to decide the image, basically. Yeah. But I mean, people might use it that are doing screening. They might use that same cutoff for referral as well, because most people that are screening aren't necessarily doctors. They're going to be school nurses or other paraprofessionals that might be involved in the process. So on exam, obviously you want to kind of look at the patient in the standing position and evaluate their shoulder height. Look for scapulary symmetry with curving. Usually one side looks a little bit higher than the other. Scapula may wing out, or because the rib hump look like it's closer to you than the other side. And then also you can see some asymmetry in the waist creases. So have somebody in a gown, or at least exposed enough that you can view their back, open it up, and view them from the back. Have them do the forward bending test. Again, you see a significant rib hump. Probably your X-ray is going to show a degree of curvature of at least 20 degrees by the Cobb method. And then also, lay them down and look for leg length discrepancy. So when I do that is I have somebody lay down, I have them bend their knees, lift their bottom up off the table, and then set their bottom back down. Then you pull their legs out together. Because sometimes people will lay down on the table a little bit crooked and not be completely lined up. So, and then you kind of look at their malleoli, where the level of where their patellas are, and compare side to side. And that's a reasonable way to try to pick up some significant leg length difference you might see. I would say anything more than a couple centimeters might be significant. If it's less than that, I mean, there's probably a lot of us out there that have a centimeter difference side to side, walking around, and we're, for the most part, fine. Interestingly, this kind of pearl of this unilateral cavus foot, which I've never seen in my life, but somebody's got a really high arch foot on one side, it can be a manifestation of something going on within the spine, again, some like neurologic tumor or that type of thing. So if you see something like that pop up, either on boards or in your office, think of interspinal pathology. So get another picture, just kind of the forward bend test. So also an exam, once you've done that, make sure you do a good complete neurologic exam. And then the other thing you need to kind of keep in mind is looking at their physical maturity. So breast development in females, and then whether they've started their periods in males, pubic hair growth, axillary hair growth, facial hair, those kinds of things. If you want to, you can do a testicular exam and throw that into your Tanner staging. But basically kind of getting a sense of where a kid is in his growth curve. Oftentimes just asking the parents, have they hit their big growth spurt? And they'll tell you, oh yeah, shoot, he shot up six inches in the last year, or those types of things. Or no, they haven't really started hitting their growth spurt yet. So those are good things as well. And then make sure you identify any red flags. So like nighttime pain, I'm never real, always makes me a little bit worried in anybody, or those bowel or bladder changes or that type of thing. So again, severe pain, work out for other causes, things we've mentioned. If they really got a lot of stiffness in the morning, or stiffness that they can't do activities, again, think about some of rheumatologic issues that might come on. And then if they actually, when they bend forward, they kind of deviate to one side rather than seeing the rotation. You actually, as they bend forward, their whole body goes one way. That would just be a reason to maybe keep in the back of your mind there may be something going on in the spinal cord itself. And rather than just stopping at X-ray, you might do some more advanced imaging with an MRI. So what things do what do you do when you image somebody with scoliosis? Well, you start with what's called a scoliosis study. Back in the day when we had plain X-ray, they basically would do 3 different X-rays and kind of piece them all together to have this kind of PA view of the spine from the shoulders all the way down to the tailbone, and then you do your measurements. Well, now with digital X-ray, you just order your scoliosis study, and digitally they stitch it all together. So, but you have to order it that way. If you just order a thoracic spine or lumbar spine, it's not going to be pieced together. You can still get the information, but it's harder to make your measurements. So all these are shot PA, and when you look at them, you want to look at them like you're looking at the patient from the back. So the heart's going to be on the left side as you're viewing the X-ray, if that makes sense. I think it's always wise to at least get a lateral view of wherever you think the curve is. Get a lateral thoracic or lateral lumbar or both. And that's to pick up kind of that failure of segmentation of the spine, which is a lot of times a little bit easier to see on that view as opposed to just your scoliosis study. So then you got to do your measurements. The standard way to measure is the Cobb method, which is shown in the picture there. So you basically find the most tilted vertebra above the apex of that curve, and then the most tilted vertebra below the apex of that curve. You draw a line off them, and then perpendicular lines, off those lines where those cross, that's the degree of curvature that you find. So back in the day, I used to do this with a pencil and a ruler, and I'd mark up the film. Now these days, it's all integrated into your packs. Usually there's a little button you push on for, either spine Cobb angle or something that will give you that, where you just basically draw a line on one vertebra, draw a line on the other, and it gives you the degree of curvature. So it makes it nice and easy. Again, when you look at the measurement, like how accurate is it, there's anywhere between 3 and 5 degrees of difference, even in yourself remeasuring, that you might come up with. So, and between observers, it can be anywhere from 5 to 7 degrees. So a significant change is probably something over 5 degrees, from one film to another. As far as like as far as thinking this curve is progressing, or we might need to do something if it seems to be progressing quickly. So I just leave that kind of 5-degree change in the back of your mind. The other thing you want to do, and this is you're going to have this information on a typical scoliosis study, is you'll have a view of the pelvis, or at least the top part of the pelvis, and then that gives you if you're Tanner staging or by history, you wonder kind of where this kid is developing. This gives you some good information. It basically measures the ossification of the iliac crest. It's graded from 0 up to 5. 0 is you don't see anything on the apophysis. 1, you're going to see it basically on that kind of front anterior edge. 2, it kind of basically progresses from anterior to posterior. So as it shows kind of how they divide it up into 25% divisions of the iliac crest. If you see the whole thing and it's not fused, that'd be a 4. And then once it's completely fused, that's a Risser grade 5. So Risser grade 5 is something that's completely skeletally mature, and we'll start to worry a little less about curvatures progressing once somebody has reached full skeletal maturity. So knowing kind of where somebody is on the Risser grade lets you know kind of how much more bone growth they're going to have, and at least the risk that the curve progresses. So MRI indications with scoliosis, they're really all relative indications. You don't need to get an MRI in every person that comes into your office with scoliosis. You might consider it in the left, somebody has a left-sided curvature. It does happen in a small percentage, so it's, that may be completely normal. But, as we looked at the ratios before, most of the idiopathic scoliosis occurs with a convexity to the right. So left-sided curves come in your office, you might think about it, especially if there may be some other things historically that make you a little more concerned. Again, if they have pain with forward bending, or they deviate to one side with forward bending on the forward bending test, certainly if they're short of breath, if they have positive neurologic findings, or something on their neurologic history that makes you concerned, then get it. Better to have, get it and find nothing than miss something and that goes on too long. In curvatures greater than 20 degrees, again, a very relative indication. I certainly don't do that in every kid. A lot of times by the time they're getting to 20 degrees, I'm not taking care of it anymore anyway. I'm sending it on to an orthopedist, pediatric orthopedist that takes care of it. Let them decide if they want it. But again, something that you might consider, and then really any other red flag in your mind that makes you worried that this is something other than idiopathic scoliosis, getting more advanced imaging can at least rule out some other things and give everybody some reassurance. So I think the most important thing, and the thing that's most time consuming with scoliosis, is just talking to parents, and letting them know what to expect, and sometimes alleviating some worries and other things that come along with it. A lot of people have a lot of fears and misconceptions of what it's going to do, and it's going to disable a kid, or make them have back pain for the rest of their life, and those types of things. So giving them good information is helpful. You can certainly have a handout that has a lot of this stuff in it if you don't want to sit and talk to them. Talk to the patient, or you're busy. But really, as far as you're determining risk for a kid, and that's probably the most important thing to really relay, is based on the age, their skeletal maturity, and the degree of curvature when they show up in your office. So all those things. If it's a really small curve, the kid's almost to full growth, and they don't really have any issues with it. A lot of times I'll just maybe say, hey, let's repeat an X-ray in 6 months, make sure this isn't getting worse. If they're a girl that's 14 to 15, she's probably not growing much anymore. You can see them back stable. Probably say, it's a curve that's like 10 degrees or 11 degrees, or say, there's probably no reason to follow this anymore. Certainly if something comes up, let me know. So reasonable things and reasonable ways to approach it to give somebody an idea of kind of what to expect. Basically, just again, to keep in mind, females have a 10 times risk of curve progression in all categories, depending of the degree of curve compared to males. So just a data point for you. So progression of curvatures at bone maturity. So you got a kid that's skeletally mature. If they're in the 30 to 50 degree range, that curve is likely to progress anywhere from 10 to 15 degrees over their lifetime. So again, you're talking about somebody that's a pretty significant curve already. They've reached skeletal maturity. What do you do? Again, in most instances, and this would be me too, if somebody's got a 30 degree curve, I'm not taking care of it anymore. I've already referred it on, but again, just information. Curves that are greater than 50 degrees at maturity progress 1 degree per year. So you can see, because of some of this information, why surgeons and people will start to recommend doing something to these curves, because of the risk for progression to at least something a little bit more significant over time. So progression is really less likely in a skeletally immature boys and girls with have a Tanner stage 4 or greater, and also have less curvature. So less than 20 degrees at any time, it's really less chance that the curve is going to progress. And anything less than 30 degrees of bone maturity also is also less likely to progress over time. So what do you do? So kind of two categories: anything from no curve, which really isn't scoliosis, up to 20 degrees. If they're skeletally immature, you just observe them. Have them do some core strengthening, flexibility. Those things don't really affect how the progression of their curve, but I think can help some of the postural related problems that can sometimes arise. And then you really just kind of X-ray them probably every 6 months, especially through that period of rapid growth, making sure that the curve doesn't progress. Anything up to 40 degrees in a skeletally mature person, you can do the same treatment, where you're just going to observe, X-ray every 6 months. I think with a 40, somebody that's skeletally mature up in that 40-degree range, again, you're going to, after so many X-rays over a few years, you may say, hey, this thing hasn't changed in 3 or 4 years. You may not choose to keep following it unless they start to have issues. So what about these ones that are over 20? So for me, I'll take care of scoliosis or follow it, if they're less than 20 degrees. When they're getting that 20-degree range, or say they're close to 20 and they're right at their period of rapid growth, I a lot of times at that point will get them to an orthopedic surgeon or somebody that kind of manages scoliosis, or at least sees more of it than I do. So curves in that 20 to 40 degree range in somebody that's skeletally immature, that's when most orthopedists will consider bracing. You could certainly hold on to these and do bracing yourselves if you want to as a family doc, but it's such an infrequent thing. I think it just gets you're not super comfortable doing it most of the time. So there is something called a Milwaukee brace, which is kind of the classic traditional brace that they put people in. There's other types of what are called thoracolumbar sacral orthoses, which is what a TLSO is. Basically, the goal of the treatment is to prevent progression of the angle deformity. There are some studies out there that suggest these things actually work. The one using a Milwaukee brace for 16 hours a day just versus observation in 20 to 40 degree curves. Only 40% progressed to surgery for the kids that were using Milwaukee brace, and almost 70% progressed to surgery if they were just kind of observing and doing nothing. The most recent study, which was in 2013, there's 242 patients, and this was all patients that were in the United States. So it can kind of translate into in the population that you're going to see. Success was considered keeping the Cobb angle less than 50 degrees in these adolescents. Bracing was 70% successful in accomplishing that, and observation similar 48% came out of the other study. So the number needed to treat is only 3 to prevent possible progression to considering surgery. So pretty effective. In a little less than 10% of people that were braced had problems with skin adverse effects. And really, these braces aren't necessarily fun to wear. And you can imagine being an awkward middle schooler and having to walk around school with something like this on that's sometimes hard to hide. There's those issues that can come up just from a social and mental standpoint of having to wear something like this all the time. But on the left of the screen there is what kind of the Milwaukee brace, and on the right is this plastic TLSO. That thing would get really hot, wouldn't be very breathable. But there are lots of these things out there that you can orthopedists will use. So I think bottom line with those, it's good to be aware of what they are and the names of them, but you're most of the time as a family doc not going to be prescribing them. If you have a resource in town, somebody that makes these braces, they're going to be a good person to use if you're going to choose to do that. Compliance is really tough with these because, again, who wants to wear that thing around most hours of the day for year after year? Not a real fun thing, but they are effective in preventing progression of the curvature compared to natural history. It doesn't correct it, so you're not going to improve it. You're just hopefully slowing the progression compared to just watching it. Again, wearing the brace can cause anxiety, depression, just other body pain from pressure points and things like that. So they're not ideal, but the best we can do. What about physical therapy for kids with scoliosis. Does that do anything at all? Cochrane review in 2012 said there was really no benefit for physical therapy in adolescent idiopathic scoliosis. There is an interesting randomized controlled trial in Italy. So 110 patients, and I didn't read the study, so I'm just going off kind of the way it was described in what I read, but it's called the Scoliosis Specific and Task-Oriented Exercise. So they had some protocol that they made up and had, you know, their intervention group do it, and then the other group just did traditional kind of physical therapy, which in most communities, if you order therapy for somebody's scoliosis, that's what they're going to get. So if you're really interested in like, what is this? I'd say go look the study up to figure out, you know, how are you going to tell your therapist what to do with these kids? I think there's a small degree of change in this study, and honestly, like if you think about what's the inter and intra observer error in measuring your Cobb angle, the difference in both of these is within that error. So I don't know how great it is to really say that this truly made a difference, but you can see the data there that the treatment group had actually improved their degree of curve by almost 5 degrees. The ones that were just traditional therapy, their curve increased by 2.8 degrees. So, and all of these, these are obviously patients that the curve didn't progress much anyway over the time that they did. They followed them. There was 12-month follow-up mentioned, and then even up to like 42 months in one part of the study. So I don't think everybody was able to be followed to that point though. So therapy, make your own conclusions based on that. In my opinion, is probably not necessarily that effective. So what about surgery? Well, if you're, Tanner stage 4 or less, have a curvature somewhere in the 40 to 45 degree range, they might consider fixing it just because of they're still going to grow. The degree of curvature can progress over time. If they're skeletally mature and have a curvature more than 50 degrees, a lot of times they will consider fixing it. The surgery is fusion. A nice picture of a girl that had scoliosis and then pre and post operatively. Really long incision back there. Did anybody ever get to scrub in on a scoliosis surgery during med school? No, I did one. It's crazy. It really is, to see how much of that spine is opened up and how many wires and laying those rods in there, and then how they crank things. It's nuts. Honestly, when you actually see it done. You can Google it probably these days and watch a YouTube video of it. But interestingly, there's really no trials to prove that doing surgery is better than bracing as far as patient-oriented outcomes and how they feel. So it's really unclear if it improves long-term symptom management or quality of life. No, and I think the bottom line is nobody's really done the study. Nobody's really looked at it and collected the data. But a significant curvature, surgeons oftentimes consider fusing it like this. So they're called Harrington rods. They can use growing rods for kids that still are going to gain some height that will adjust as they grow. Operation takes 6 hours, usually several day hospital recovery. It's a big deal. Had a neighbor friend, their kid had it, and he after the surgery was 5 inches taller than what he was before. I mean, he's gained a ton of height from having the surgery done. What about if you're playing, you got an athlete that has scoliosis and, has surgery, what can they do after surgery? The traditional approach is basically they can do non-contact sports, but nothing contact. In my mind, that probably makes the most sense. You have a rigid spine, or you let them go out and play football or wrestle or, something like that, where it just doesn't make a whole lot of sense to me. There is a progressive approach after fusion that's talked about, where at 6 months they can do, all non-contact sports, and then after a year could even do contact sports. There's really not many people that kind of ascribe to this, but it is mentioned out there. There's some trials that have shown the good results with gymnastics, basketball, wrestling. So I don't know if basketball, if I'd be that worried about, honestly. Wrestling, I would. Gymnastics, I don't even know how you do some of the maneuvers with a spine fuse like that. But I guess it depends what level and things that you're participating in. So in conclusion, there's definite criteria for kind of how you evaluate, how you monitor this, and stages of treatment, when you should do bracing, when you should consider surgery. So anything less than 20, you're probably good to observe. 20 to 40, bracing. Over 40, you're probably going to, think about, potentially doing surgery. Watch for red flags in the patients that you see. Make sure they're not having other concerning symptoms, especially, pain that you see seems more severe. And kind of know when you're going to refer. Rapidly progressing curve, there's red flags. Sometimes you as the family doc lay everything out before the patient and they're still kind of skeptical. They're like, I'm not sure you know what you're talking about. Fine, you know, it's okay to send it on to a specialist and let them, tell them the same thing. And honestly, that builds trust in you. If they go somewhere, a specialist, and they hear the same words that you just told them, they're like, they do know what they're talking about. So, and I never have a problem with that. I don't ever take that personally. I think that's a good thing. You know, sometimes patients just need to hear things twice from who they consider the expert. And I think that's a helpful thing. You know, again, patient education, both patient and family is probably where you're going to spend the most time with people with scoliosis. I think you as a family doc can manage most cases that are going to come into your office. And then, you know, I'm a sports med doc, exercise is always good. You know, I think it's good to keep people active. Try to reiterate that, hey, yeah, you got a little curvature and it's fine, but it doesn't mean that you can't do anything. You know, you're just like anybody else. You just have a little curve. You can do all the sports that anybody else can. So, questions I can answer. I didn't take up the whole time. But.
Who do you refer to for surgical correction?
So the question was, who do I refer to for surgical correction? I tend to pick somebody down at one of the pediatric orthopedists, like down at Riley or Peyton Manning, as far as, you know, here. There's really nobody in our group that takes care of it. So.
Where do most of your cases come from? Do they come from like school scoliosis screenings or sports physical? Did you pick up dental exam?
Yeah, I would say it's most of the ones that I see are just either sports physical or just parental concern in some way. Those are the ones that tend to come to me. Honestly, it's not a large percentage of my practice in what I see. I mean, it comes in spurts. I'll sometimes see 2 or 3 in a row, you know, within a couple months, and then I won't see somebody for a year with scoliosis. So I don't know who else they're going to. I'm certainly not the only provider out there that can take care of it. So. Any other questions? It's good to see Austin here with his elbow still. Yeah.
I was going to mention, actually, I think I have a 15% curve on my back. So it's always good to get my elbow on my back.
All right. So that's learning point for me is I need Austin at every lecture that I do because he always has something applicable to what I'm talking about. So he had the elbow infection last time I was here. So now we have scoliosis. Exactly the opposite. He's got to be here. All right, guys. Thanks a lot.